Hey everybody, welcome to Live with Amy. I am here on Thursday, the 21st of January, and I am Amy Eicher from Restoring Venus, and I am an author, educator, and your pain coach. And today we are talking about diagnosing SI joint pain. I know for many of you, the SI joint can be a real pain in the butt, if you will. And I thought I would come on and share some facts about diagnosing SI joint pain that people may or may not know. Um, well, we should probably start by explaining what that pain feels like, right? So, SI joint pain is part of low back pain, and it is usually felt off center of the spine. So like if you feel, your back and your vertebrae, it's off to the sides is where it is most commonly felt. Most people kind of when they're first experiencing it talk about it like, well, it's not my hip and it's not really my back and it's kind of my butt, but maybe it's too high to be my butt. Like if you're having a hard time explaining where the pain is, there's a very good chance that you are experiencing pain in your SI joint. It hurts a lot more with movement than it does, or like with transitions. So sitting down, standing up, walking, stairs, laying, rolling over, those kinds of things are usually where people notice it first. Often comes on after pregnancy. Very active people, runners, tend to notice it. Dancers, those that do a lot of Pilates or yoga. These are a lot of the places where people feel like they get injured and this pain starts for them. So weightlifting is another place. As some of you may know, I was a swimmer and I first experienced that pain in the pool. So there is a gentleman by the name of Dr. Fortin that has done some research into the SI joint, and for whatever reason, he is fascinated by it like I am. I don't think he had pain though. But what he did was he took healthy individuals that did not have pain, injected them into the SI pain or into the SI joint with irritant, and mapped their pain patterns. Now, the interesting thing about this study is that nobody had pain go below mid-thigh. So I think that's really important to remember, because when our doctors are doing their diagnostic flow charts, if we've got pain that goes below mid-thigh, usually they're looking at the lumbar spine. And that's really important for us to understand. It's not that it can't be because your SI joint is irritated, which it's not coming from the SI joint directly, right? If that pain is radiating, but it could be from tight muscles in the hip that are affecting the sciatic nerve. All of that pain will be, like, if it is sciatic nerve pain, if it's coming from the sciatic nerve or the nerve root, all of that pain is going to be felt in the back of the leg. The sciatic nerve does not give power or sensation to the front of the leg, and that's another important fact. So if you're having typical posterior, back-sided SI joint pain, you're going to feel that mostly in the bottom, maybe across the low back a little bit. It's going to kind of feel like it's the hip, and it transitions. Long periods of standing, long periods of sitting, long periods of walking are not going to be your favorite thing in the world. A lot of people say that the joint feels unstable, it feels wobbly, your balance feels off, and these are things that can all be very, very true with SI joint pain. Now, it gets a little bit tricky when we start talking about diagnostics. And in the SI groups that I've been in, I see people get very angry when doctors won't immediately go to imaging. And I'd like to explain that. So in medicine, there are guidelines for how we for how they diagnose things. And it's really important to understand that the best doctors are the ones that follow these guidelines because there is research to them. And research in Australia, the United Kingdom, and the United States say that for low back pain, which SI joint pain is part of, imaging is not a good plan unless things are very specific, right? So, and we've talked about those nasties and when we do need imaging. And if you'd like a refresher on that, head into the units section and you can take a look at red flags, and that'll give you the information you need on when imaging is really important. Loss of bowel and bladder, radiating pain and weakness, like I can't straighten my wrist, or I can't straighten my foot. I'm not as strong as I used to be because I've been sitting around. But, and loss of reflex. Those are really good reasons to have imaging. So SI joint pain is low back pain, and we know that 99% of that pain isn't something that we need to be like heading to an emergency room for. That it's minor tissue damage, it's things that will heal, and that's good news, right? So if your pain persists and you've gone to physical therapy and stuff is irritated and it's not settling down, and you go back to the doctor and they do take an X-ray or MRI, nothing should be all that remarkable. There really shouldn't be anything there to be seen. And if there is, like a tumor or a fracture, that's not SI joint dysfunction, that's a tumor or a fracture, and it needs to be taken care of. Bilateral sacroiliitis, when they see inflammation on both sides of the joint, that should lead you to a rheumatologist. It's very important that if you have bilateral inflammation, that you should get that checked out by a rheumatologist. That is not part of mechanical low back pain's flowchart. So that will often get shoved off and pushed off as though it's unimportant. And like if you see it, you really should go. Autoimmune diseases that would come up at a rheumatologist, like ankylosing spondylitis, actually start at the SI joint. So if you've got inflammation in both sides of the joint, it's worth getting that ruled out earlier rather than later, because you can exercise and do all of the PT things, and that can be helpful in managing the sensitivity of the area. But it's not until you get on the it's not until you get on the medication for autoimmune diseases that they would find that you're really going to start to see improvement, because it's a completely different disease process. So that's really important. If nothing else is seen on your scans, I would also strongly encourage you to go get a checkout by a pelvic floor physical therapist. We often forget, while we're so focused on the glutes and the IT band and the psoas and all these different muscles of the pelvis, we often forget that the internal muscles, the muscles of the SI joint, or like the muscles of the pelvic floor, connect to the sacrum and other parts of the pelvis. So it's very important to make sure that those are okay if nothing comes up on your scans. And especially if you've had children or you're having increased pain during your period, a pelvic floor physical therapist is the perfect person to see, because they have expertise in this area. And all of the orthopedics seem to forget that these are also muscles that can be contracted, that can cause things to be wonky. So, pelvic floor physical therapist, you should check them out. All right. So let's say something comes back on your scan and there is a hip issue or an issue with your lumbar spine that they see. That's a stopping point on the diagnostic flowchart. If you have something visible on scans for your lumbar, low back, right, your lumbar vertebrae, or your hips, that's a full stop. Those need to be treated and checked out before anybody should go any further with trying to diagnose you with SI joint pain or dysfunction or whatever we're going to call it, right? Back pathology and hip pathology are a hard stop, and you're supposed to deal with those first before you go any further, okay? So let's say you've gone to PT and you've done all the back stuff and you've done all the hip stuff, and let's say you even found me, and so you've been doing the sensitivity, desensitizing, and working on your nervous system as a factor in your chronic pain as opposed to just tissue, right? Let's say that's not really working. All right. So the next step after a clear back, clear hips, Amy's addition of please go see a pelvic floor therapist, and if you have bilateral sacroiliitis, go see a rheumatologist, right? So we've got all that cleared out. Everybody says you're great, you're good. It's got to be your SI joint. Okay. Then how do we determine that the pain is coming from the SI joint? There are 6 provocation tests that have good validity. That means they tell us what we think they're telling us, and that's that it hurts with these movements. Okay? You're probably familiar with these. I have a long history of hating them because they always hurt a lot. I had to have another driver if I knew that they were going to be done because they would flare me up so bad, because my tissue was so sensitive that the collection of these tests could really make it so I couldn't drive and would really increase my pain. Now, that's what they're supposed to do. They provoke your familiar pain, right? So in research studies, they have found that some of those tests are particularly sensitive and can diagnose with good accuracy that the pain is coming from the joint. Now, I will say you've probably already told them that. You pointed to where it hurt, and these tests are really just the only thing that they can confirm is that it hurts when you do that, right? They do not give you any information as to why they hurt. So if nothing is on the scan and the rheumatologist says you don't have any autoimmune diseases going on, and the pelvic floor physical therapist says, things are cool, what these provocation tests tell you is that you have sensitivity. You've got pain in that area. You already kind of knew that. Well, so if they don't cause pain and sensitivity, then an SI diagnosis should not be pursued any further. There's no need. That's not where your pain is coming from, okay? It may be where you're feeling your pain, but where you're feeling it and where it's coming from are 2 very different things, and that's important to understand. So that's what happens if 3 of those 6 tests do not provoke your normal pain, because some of those tests also have crossover with the hip. Okay? If 3 of those 6 tests are positive, then you go on to an SI joint diagnostic shot. Okay? There is so much confusion about this little test. I tell you, I don't understand it. So SI joint diagnostic tests are supposed to be done in a group of 3 because they are not very specific. Like, they don't specifically tell us where the pain is coming from, because in 87% of the population, our SI joint capsule is torn, which means the numbing agent leaks out. So it may or may not be the joint. It could be the surrounding tissue or the surrounding nerves that are just irritated. And that's what the test is going to tell you, is that there's pain in this area. And again, you already knew that. Now, when this test is administered, it should be with visualization. The doctor should be able to see via CT scan or X-ray or ultrasound or some kind of imaging that allows them to see inside your body that the needle is indeed inside the SI joint space, if it's an intra-articular injection, which it's supposed to be. Intra-articular means in between the joint. Extra-articular is just around the outside of the joint. And there are people do those as well. But they're not looking for pain coming from the joint surfaces. They're looking for pain in the general area. Okay? Which, sadly, since 80% of our joint capsules are torn, that's really the information that we're getting, is that something in that area is irritated, and the numbing agent chilled it out, which is great because it's so nice not to feel that pain and sensitivity and irritation, right? But people get really confused on whether or not they're supposed to pay attention to what happened with the numbing or what happened with the steroid. So the numbing is the diagnostic portion, right? That lasts for minutes to hours. I don't think it lasts for more than a couple of hours with most of those cane medications. So the doctor is looking for a 75% reduction in your familiar pain right after the injection, right? Within let's call it within an hour of the injection. Now, a thorough doctor that is giving that injection should repeat those provocation tests on you to see if those motions still provoke pain after the numbing agent has been administered. Lots of them don't. So if this is a procedure that you're considering, I would highly suggest that you invite your doctor to do these provocation tests after the medication has been administered. Now, in most settings, because this is expensive and there's a cost to this, often what doctors will do is they will provide the numbing medication for the diagnostic, and then kind of as an extra bonus, they will give some kind of steroid right after they've given you the numbing agent. It is not diagnostic in any way, shape, or form. Hi, Rebecca. She says, like, none of mine did those after. I know. And that's why as patients, we need to be educated about these processes so that we can kind of educate our providers on how this works. But wouldn't that have been great if you knew the stuff that used to make it really hard for you to drive the car? Like if they did the exact same tests and there was no pain, wouldn't that be at least assuring? Like I think it would have been. And the tests are not that hard they're not that hard if you can train a PTA to do them. It is not rocket science. Sorry. It's just not. So PTAs know how to do these tests. Like, we can't interpret them, but we can perform them and then say the patient said it hurt, the patient said it didn't hurt. So if a PTA can do it, an anesthesiologist can certainly perform these tests, is kind of my point. But the steroid injection that they often give with this, number one, if you're not a fan of steroid injections, you can tell them no. That's what I did. I told my pain management doctor, I said, we've done steroid injections in other bits and pieces of me. I don't want any more. No more steroids. I don't like the way it makes me feel. Like, they never help. So, and I have no signs of inflammation on any scans. So how about we just skip that? And he was like, okay. So all they did was the numbing agent for me. And it took away all of my pain. And my joint capsule was torn. So what did that tell me? Well, told me that I had pain where I pointed to, and I said I had pain. So I know we want and that's the end of the SI joint diagnostic line. That's it. That is how a medical doctor diagnoses SI joint pain, right? So either you have pain or you don't have pain, but there is no test that tells you why you have pain. Imaging doesn't tell you why you have pain. It can show fractures and tumors and stuff encroaching on other stuff and pinching things, right? But we have to go further with that information to make sure that the picture is valid, right? The provocation tests, all they do is provoke pain. So it provokes pain or it doesn't. The injection takes away the pain or it doesn't. It doesn't tell us why. So there are limitations to the gold standard, which is 3 provocation tests and 3 injections, not 1 injection, 3 injections. That's the actual gold standard for SI joint diagnostic testing. Again, I repeat, all it tells us is that you had pain where you said you had pain. So there are some rather smart people up in Canada that have been doing research and making suggestions. And that paper called Changing the Narrative Around SI Joint Dysfunction is linked in the blog post under the SIJ units in the Facebook group. And I do strongly suggest those of you struggling with SI joint pain, give that a read. The reason that I say that is because we're understanding more and more that low back pain, which SI joint pain is part of, is what's called non-specific low back pain. It means we can't find the exact tissue. Maybe it's this muscle, maybe it's that tendon, maybe it's this ligament, that have irritation, not full-on tears. Those are visible, right? So this is not dramatic stuff. There is a bunch of tissue that is irritated, and our testing is not specific enough to tell us what tissue it is. That doesn't mean it's not hurting. That doesn't mean you don't have a sprain or a strain. All it means is the testing is not sensitive enough to tell us what structure it is. The good news about this is, if we think about it in terms of sensitivity and not like horrific damage, we know that the body will heal itself. So sprains and strains happen all the time, and the body will heal itself. What we do have is a ton of nerve endings in the SI joint area. There is a ton of information that comes from that part of the body, and it can get super sensitive. So if we know that it's sensitive, well, then we can make changes and adaptations for a short time, like using crutches, like wearing an SI belt, like taking over-the-counter medications, like taking prescription medications. Stretching if it feels good, movement that feels good. We know that these are things that we can do, whether it's your back or your facet joint or your SI joint. At the end of the day, you guys, please don't kick me out of the group. I mean, I know it's mine, but don't kick me out of the group for this. The reality is, it doesn't matter which of those tissues is sensitive. We need to desensitize it. So we need to make changes for a time to bring the pain levels down so that we can get moving again, right? So once all the scary nasties have been ruled out, if there's nothing on your scan, that's actually really good news. It means you're one of the 99% of people that has non-specific low back pain. Yours is coming from, something in and around your SI joint, but you don't have to know what tissue it is to fix it. And I think that's really the message that I want you to hear today, is that hopefully you've gotten a better understanding of the tests that are done and the limitations that they have, but that simply because they can't find an offending tissue doesn't mean you can't get better. And that is the brilliant part. So I hope that you keep moving beyond your pain. I hope you keep learning. I hope you keep listening. Next week, we're going to talk about the pain pathways of the SI joint and how they differ from sciatica and piriformis syndrome. So stay tuned for that. But I hope that this helps understand a little bit more about the limitations of testing for SI joint dysfunction. We'll see you next week.